Now, I want to talk about the importance of trials in pregnancy. So up to very recently, pregnant women were not included in trials. That's a bit odd, isn't it? When you think about it. You know, half the population is female, and then let's say another half of those are between the ages of 20 and 50 and are likely to be pregnant. So I'm very passionate about having trials that we do in our network delivered to pregnant women if that trial is appropriate. And we've 3 ladies here who have participated in those trials. Now, you will remember this picture coming from Time magazine, and it tells us how important pregnancy is to programming us for our whole life. So the baby in the womb here is being programmed for the rest of their life. What we do in this pregnancy can make that better or it can make it worse. Also for this pregnancy, how we deal with the mother will impact on her future life if she has diabetes, particularly in cardiovascular illnesses. So it's a really important time. If we look after pregnant women, especially those with diabetes, properly, we have healthy mothers, and we can almost certainly say we will have healthy children. More importantly, if we look after these women when they're pregnant, what we do in the pregnancy will impact their future long-term life, and therefore they will be healthy into older age. And that is really important. That is a new phenomenon that has been coming through in the last number of years. Okay. So when we look at what you could modify in pregnancy, I'm sure you're all aware smoking isn't good, drinking isn't good, excessive weight gain is not good, and that's something we focus on. You know that if you take vitamin D, it helps. You know that if you take folic acid, it helps. But what we have been really interested in, what I've focused on over the last 35 years, is glucose. So a little bit of glucose is good for you. Too much glucose definitely is not good for you, especially when you're pregnant. So, how common is the disease where you have too much sugar during pregnancy? So if we look at the best available evidence from the IDF, 1 in 6 pregnancies have a sugar problem, okay? Of that sugar problem, some have type 1 diabetes, some have type 2 diabetes, some have rarer forms of diabetes, but the most common form of diabetes is called gestational diabetes. And about 84% of the group that we're talking about will have gestational diabetes. If we look globally, there are 21 million births annually on the globe. And if you calculate the number of women who will have gestational diabetes, it's just under 3 million per year. And therefore, there's 3 million infants also. If you look at that in Ireland, we have about 55,000 births, and that will give us an estimate of just under 7,000 GDM cases annually, and that's also 7,000 infants, and we're supposed to be trying to deal with the health of both. So if we get everything right, we can produce a baby that's normal in size for gestational age and free from any morbidities. And certainly as a clinician, this is what I want at the end of a period of looking after a woman. And this is what the woman wants also. So this is all that matters to the woman who's pregnant. Sometimes, however, if we don't get the glucose control correct or tight enough, we have a baby that has suffered from overnutrition in the womb. And these babies, they look big and chubby and lovely, but they are not healthy babies. And they're not healthy babies for the duration of the perinatal or post-pregnancy period in their first month of life, but they're also not very healthy going forward because we're predisposing these infants to obesity, hypertension, and cardiovascular disease in the future. So the onus is on us as clinicians and practitioners, and the onus is on things like a diabetes clinical trial network to really examine what we're doing and ask, can we do this better to get sugar better controlled? So over the life course of somebody who has had gestational diabetes, what we can say is that gestational diabetes identifies a pregnancy that's at risk of adverse outcomes. It identifies a woman at risk of future diabetes and cardiovascular disease, and it also identifies an infant at risk of future chronic metabolic diseases if we don't do things properly. So it is a window of opportunity in which we can put in an intervention that has important outcomes and consequences for the pregnancy, but also for future health. So the current treatments, I sit in clinics and have done for 35 years looking after women with diabetes and pregnancy, and there isn't much available to you. There's lifestyle intervention, which is diet and exercise, and that's followed by insulin usually. Now, if you're taking insulin, it means you're injecting 1 to 6 times per day, not very pleasant. You're pricking your finger 7 times a day, not very pleasant. And I used to wonder, well, why aren't we using metformin? Why are we not advocating the use of metformin? And this is an old-fashioned treatment. It's cheap as peanuts, but we're not using it routinely. So I went to look at the literature to see why we weren't using it, and clearly, equipoise exists in the use of metformin, and this exists because there's a gap in the literature related to knowledge. And that gap relates to the fact that there was no randomized placebo-controlled trial of the use of metformin in women with gestational diabetes prior to the onset of the eMERGE trial. So why might metformin be useful for these women? Well, it's around for a long time. We have a significant body of knowledge and good safety data. You can give it orally, and women would much prefer that than sticking needles in. It's cheap and affordable, so that's really important for healthcare and for the amount of money we spend on it. No storage issues, so you'll hear people putting their insulin pens in the fridge. We don't have to do that with metformin. There's excellent compliance with the drug, and of course it has a global reach. And if you look at low and middle income countries, a lot of them can't afford insulin. So the women there really get very little. So if we could prove that metformin would be useful, then that would be of a benefit globally. So with colleagues in the clinical research facility and with colleagues who are part of the clinical trial network that Peter has alluded to, we discussed and debated. We designed a trial which is a very high quality because it's randomized and placebo controlled, and we implemented the trial and we have a set of results. So our question was very simple. It was, among pregnant women with gestational diabetes, does early metformin added to usual care, which is your lifestyle intervention, reduce the need for insulin or a fasting sugar greater than 5.1 at week 32 and 38, prevent excessive weight gain, improve maternal and neonatal morbidities, and reduce the cost of care for these women when you compare it to a group of women who have lifestyle and are given placebo? So our primary outcome was a composite of either did the woman require insulin or was her fasting sugar greater than or equal to 5.1. So that's very tight control on the bandwidth of what we do in diabetes. We also collected a number of important secondary outcomes on the baby, which are really important for baby's health and important to the mother. And we included a set of outcomes equally important to the mother, like gestational weight gain, overall glycemic control, did she need a cesarean section, how long was she in hospital for, and of course acceptability of treatment. So we came up with a number of hurdles on the way. We had COVID, 2 cyber attacks, one in the university and one in the health system, and of course we had Brexit. And Brexit had an impact on things like sourcing your placebo, sourcing your metformin, getting it here, paperwork related to it. But I'm delighted to say that despite the hurdles, we have completed the trial. We enrolled 535 women, and we only lost 10 women to the primary outcome. So we have 96% of data to examine the primary and secondary outcomes of the pregnancy. In addition, we were able to enroll 20% of women who are non-Caucasian, and that's really important that we have that spread. In Ireland, we don't have a lot of non-Caucasian population, but we really made efforts to include those. I'm also pleased to say that we enrolled 11 women from the traveller community. I don't know how many traveller women have been included in trials up to this. So the trial has been conducted with enormous rigour, and the outcomes are exciting. I think the outcomes will have a huge impact on the delivery of how we treat patients in Ireland, but more important, how we treat people globally. I cannot share the results with you because I'm presenting the results at the American Diabetes meeting at the end of June, and there's an embargo on the data until we have that done. But after that, then, I will be delighted to share with everybody. We've now started the follow-up program of the women and children, and this is really important. When you have an intervention in pregnancy, you can't just assume everything is hunky-dory just because the pregnancy outcomes are good. You must follow the diet of the mother and the infant periodically for their lifetime, really, to see that you're not causing any harm long term. So we've started that, and then we have a maternal and infant biobank so that we can interrogate this for mechanistic studies when we pick something that's a bit unusual. So we're really delighted to have completed this. This tells us the conduct of this trial and the skill set required from a whole group of individuals gives me great hope that the clinical trial network can deliver this type of high quality research of the highest level that will impact not only on patient care in Ireland, but patient care globally. So thank you for your attention.